Dear all, we are here for a new episode of the ESD school dedicated to the ESD for recurrences or for residual neoplasia after incomplete resection. So it's a focus dedicated to this. If you like, and please subscribe to the channel and say us what you need to give us some ideas for the next episode. So please don't refrain from asking questions or from doing commentaries to help us to go further. So we will use a case to discuss. It's a 65 years old female with an EMR piecemeal into the CCOM with 2 attempts of endoscopy treatment for the residual disease, for the recurrence. They tried to do adenoma resection with snare, and later they tried to destroy with APC. 2 years later, there was still 2 small recurrences around the scar into a global area of 20 millimeter centered by the scar. And it was referred to our center for advanced resection to free the patient from any residual disease, and the patient became fed up with this because it was in fact the 5th colonoscopy for this problem. So in our strategy, we use mostly ESD for the recurrences, because we did a comparative French study with 177 ESDs for recurrence versus 98 EFTR for colorectal recurrences. Under 20 millimeter, the results are similar in the two arms. But when we go to more than 20 millimeter, we can see that the en bloc resection rate really drops with EFTR, and the R0 rate is significantly, clearly reduced above 20 millimeter and really clearly above 30 millimeters. So for us, the best strategy is ESD for all lesions, but EFTR is also a very good solution for the very small recurrences under 20 millimeters with good results. Above 20 millimeter, probably you have a better result with an ESD that will clear completely the area from recurrence and from residual neoplasia, and then you will have a one-shot definitive treatment instead of having to come back if you use snaring or APC or this kind of topics. So I will try to give you some key points, my main key points for the ESD for recurrences. 5 points are important for me. First, we should waste time, in fact, because the scarring process is long, and the softness of the tissue take a lot of time. So in fact, if you try to go to treat a residual neoplasia or recurrence in the 5 or 6 months that follow immediately the resection, it will be a nightmare, because the scarring process is not finished, the submucosa is not completely recreated, and sometimes you have still an ulcer that is quite impossible to dissect. So probably, if it is possible on an oncologic point of view, I mean, if you have the time, because it's not a cancer, it's better probably to waste time and to do the recurrence resection later, after 6 months, when the tissue becomes soft again. Taking larger margins is important, dissecting very deep, having a strong traction, and the virtual blue cut line, I will develop this point. So when we are talking about recurrences, we have the initial neoplasia, which is removed but incompletely. We have a small residue that comes back and that develop on the area with fibrosis, which is stronger at the middle than in the edges of the resection. The fibrosis repartition is probably larger and stronger initially, and it goes down with the time. And sometimes we have recurrences probably 10 years after the initial resection because the patient was lost to follow-up. And sometimes you don't see so much that the submucosa is not normal because the scarring process went to a completely disappearance of fibrosis and a submucosa which is almost normal. So once again, if oncologically it's possible to wait, it's probably better to waste time in order to have a better submucosa at the time of the recurrence management. We should also take larger margins to do the incision because it's really better to begin the resection and to enter the submucosal space into a normal area and not directly in the fibrotic area, which is really difficult to enter and to deal with, to find the good layer. So beginning very close to the lesion is probably really more challenging than going at least 4 or 5 millimeters above, far from the scar, in order to have normal mucosa and submucosa to enter into the submucosal space and to approach the fibrotic area once you are already into the submucosa and not when you are incising or doing the incision to enter in this area. Third point, which is also very important, is that if you go close to the muscle, usually the submucosa is better. You have more fibers than if you go very, very shallow where the fibrotic tissue is very strong and very large because during the first EMR, you have not removed all the submucosa. So probably the deepest part of the submucosa has never been totally destroyed and is still existing. If you go very close to the mucosa where the resection was done, you have more scary tissue that at the depth of the submucosa close to the muscle. So once again, going very deep, close to the muscle will help you to see the axis of muscular fibers, so you know that you are in the good depth, very close to the muscle, and also because probably the blue layer will still exist at the deepest part. Also, you are only fibrosis when you are shallow. The strong traction is very important because fibrosis is not soft, but submucosal fibers around fibrosis are soft. You can stretch it. So if you make a strong traction strategy, you will enlarge the residual submucosa, which is not fibrotic, to see where you have to pass. Without traction, sometimes the space is virtual and it's really difficult to dissect. With traction and with a strategy that open and stretch this submucosa which remains soft, you will have better results. And finally, it's really difficult sometimes when you are in a very fibrotic area where you see only fibrosis. It's yellow or whitish or yellowish everywhere. You don't know where you have to cut and you can damage the specimen by going to the specimen. But if you manage to dissect from blue to blue outside the fibrosis, it will help you to create a virtual line between blue and blue, cutting the fibrosis by imagining, by thinking about this virtual line which goes from blue to blue without the specimen in between. So really, when you are in the fibrotic area, please go back, try to find the two blues at the two edges of your fibrosis and try to join it with a virtual line. It will help a lot compared to trying to cut only in the fibrosis where you don't know exactly where you are and what is the axis you should follow. So finally, the complete strategy is here. You have the scar and the recurrence. We use a large incision. We use a strong traction. And then when the field is very small, we tract again to enlarge the space and remove the lesion. So the case here is a double recurrence with two small adenomas surrounding a scary area. We decided to remove all the area, going relatively far from the scarring process in order to have an area which is able to be injected and that have a good lift up to create a cushion and find the good layer outside the fibrosis. You can see that at the end the central area is difficult to enlarge, but once we will have done the incision and the trimming at the good depth, we will be able to place the traction and find finally this blue layer deep into the submucosa, close to the muscle, which is for me a good way to find again a blue layer able to be dissected compared to what we can see at the central part of the fibrosis. So we do the trimming and then we place the multipolar traction device. It's interesting to have this kind of multipolar traction device because we will need a strong traction at the beginning, but we will need again a very strong traction at the middle when the scarring process is very important. And therefore, having something that is able to be stretched again at the middle, but which is strong enough at the beginning to enlarge the space from the beginning, is really helpful, I think, because it will help you at the two most important steps of the procedure. It means at the beginning to enter the good layer, and you can see here that the yellowish fibrosis is shallow, but at the depth we have a blue layer which is under the fibrotic area, and that is not so large, but it's possible to inject it and to cut it thanks to the exposure of the traction. So yes, you should be very careful because the space is small and the risk of touching the muscle is important because the muscle goes with the specimen because of the traction. So we should take time to enlarge and to stretch not so strongly the area, but thanks to this adaptive traction at the middle, when the space becomes very small, we can stretch again to expose this small blue layer at the depth of the fibrotic area. So yes, the space is smaller, yes, there is blue at the deepest part, but to expose this blue, traction is for me the best strategy and is stronger than only underwater or gravity. Another example, which was done for an SSAP recurrence after piecemeal EMR. We can see that it's probably more an incomplete resection because all the oral part was removed with a strong scar and all the distal part was remaining. So in this case, sometimes it's more than because the physician didn't see all the lesion above the fold and cut only the area which was visible close to him. In this case, EMR seems difficult because the scarring process was really strong with an important scar. So we did the distal incision in retroflexion. We placed the tightening device of traction on all the edges of the lesion. So 4-point multipolar traction. Then we could begin after the initial resection. So once again, beginning by a normal submucosa is easier because you can find the blue layer and find the good depth. if you begin from a fibrotic area, it's sometimes horrible to find the good layer. And the last of the 4 points on the 4 cardinal points of the lesion, the rubber band on the opposite side to get a strong traction from the beginning. So we deflate and try to go far to have a strong traction. Fix on a fold if possible, because the clip is less damage if you have a fold than if you have no fold. And in this case, the blue layer at the depth of the scar was really good, and a good exposure was possible for a large part of the procedure. We stretch when the fibrosis made traction less strong. We tightened the device in order to recreate a good traction at the end, and you will see it is closing all the points together and create again a good traction on the remaining submucosal fibers that are normal at the depth of the submucosa. And finally, the exposure is very good until the end of the lesion without anything going into the field of view. And we could achieve this resection completely with R0 resection, despite the fact that the scarring process was quite strong. So we closed the defect after to be sure to see it. With the small incision method, it means we do small incision and catch it to avoid the clip sliding. Now you can also use some clips with teeth to catch better the mucosa, but a simple way to do it is also to do small incisions, and we could remove this recurrence quite easily with good results. So in conclusion, 5 key points for me. Waste time to let the scarring process being complete and getting back a normal submucosa, a soft submucosa. Take large margins, do a deep dissection close to the muscle. Strong traction is very helpful, and adaptive one is really important in this case, to have both a good exposure at the beginning and at the middle of the procedure when fibrosis is very strong. And when you have the fibrotic area, try to create line between blue and blue, passing through the fibrosis with an axis which is virtual, but which is directed or guided by your two blue at the two edges of the fibrotic process.